The broadcast is now starting. All attendees are in listen-only mode.
Pretty good at giving strokes, but would like to do that sometimes. I have nothing to disclose for the purpose of this talk. And I always wish to start with framing the problem. And one of the expertise that I have is in the treatment and diagnosis and follow-up of atrial fibrillation, which is the most common cardiac arrhythmia in clinical practice. We all know that it's a very prevalent condition right now. Figures show about 2.5 to 3 million Americans having it currently, and the projection are for an increase of this prevalence over the next 10 to 20 years. I suffer from referral bias, so for me these numbers are very low. I think there's lots of people that have a lot more atrial fibrillation than it's currently quoted. And I think the prevalence is going to increase not only because of our population lateral growth, but also because of better ways that we have to identify these arrhythmias. For example, the new Apple Watch has a software that just by having the wrist on your watch, you can detect heart rhythms and sort of record some pretty easy EKGs. And they have an algorithm that can tell if you're a normal rhythm versus atrial fibrillation. The problem with atrial fibrillation is that as much as it is a pain in the neck to identify, treat, and so forth, the biggest consequences of it from a health perspective is that it's associated with a very high chance of cerebral vascular accidents. And the cerebral vascular accidents that happen with atrial fibrillation, estimated about 70 to 100,000 cases per year, are actually more morbid, causing more long-term complications to the patient that are afflicted by it than other cases of cardioembolic events. High cost to the system, high mortality, and big problem for the system in general. I'd like to take a long view of this, talking about the embryology and going back on our first slides and constitutions in medical school. If you look at this representation of the picture in here, that doesn't really go well. Can you adjust the projector?
Like your page first.
Yeah, I think it.
Is that better?
It is better. We cut something afterwards, but it's better than having this one. Okay, sorry. So looking at this cartoon here on the left side. Oh, this doesn't work. You have an on and off button for this.
You gotta plug this in.
That's close into slides.
Yeah, you gotta plug that in.
your computer, that one in.
Plug this one into your
I think
computer.
one should work even without this.
yeah.
Maybe.
So, nice work. Maybe you can pick this up. Sorry. So looking at this cartoon here on the left, this is the embryo, the first stages of development, about 2 to 4 weeks, and it's a flat plate. And displayed on the sides is a horseshoe-shaped cluster of cells that are called androgenic cells. These are the cells that will be the progenitor of the heart. And what happens between the embryogenesis and the organogenesis in the first 8 weeks of life is that this flat plate is going to actually loop and then close together, so that these 2 areas in here are coming together in the front, forming the chest and abdominal cavity, and effectively putting this area together to form the cardiac tube that then eventually loops. We'll see some other slides of it a little later. What I want to focus the talk on is the left atrial appendage, which is one of the structures in the left atrium that we think is the most responsible for embolic strokes, especially atrial fibrillation, and I'll try to convince you of this with the next slides. The left atrial appendage is a remnant of the primary atrium that is first formed and is displaced anteriorly from the secondary atrium formation, and develops again between the 7th and 8th, about the 3rd week of gestation. It's a largely trabeculated area. We'll see some images on anatomy and pictures of it. It contains largely trabeculated areas that contain some thick muscles called the pectinate muscles. There's a large anatomical variation within individuals, and it's very well preserved throughout the animal kingdom. So looking at the embryology, on the left side, we see this cartoon that has the primary atrium that has a small pulmonary vein back in here, in this area that eventually will become the superior vena cava, inferior vena cava. There's no septum formed, and Dr. Manos will talk about the formation of the septum in his talk. And as the secondary atrium, which is the final product, actually forms, you can see this whole area that started from one pulmonary vein becomes the posterior wall, the inferior wall, and the roof of the left atrium. And the appendage is displaced right in here on the anterolateral side. Same thing on the right side, with the right atrial appendage displaced on the right anterior side, and the majority of the right atrium formed from the superior vena cava, inferior vena cava. Those are some anatomical slides that show the complexity of the relationship of the appendage with other structure within the heart, and also have to do with some of the different morphologies. On the right panel in here, this is a view from the intraatrial septum. You're looking out into what is the opening of the left atrial appendage, and then you can see the atrial appendage coming in here like a horn back on this side. And then on the back side, this is the bridge between the left atrial appendage and the left superior and left inferior pulmonary vein with a carina running here. It's a different conformation where we have, instead of a left superior, left inferior, we have a left common orifice to the pulmonary veins. And the orifice of the atrial appendage, instead of being a circular orifice, in this case is bean shaped or kidney shaped, is very elliptical. When you look at a histological section in here, that's a left superior pulmonary vein. There's some vessel vasculature and thick musculature in here on the epicardial surface of the appendage. You see the relationship. I'm sorry, you don't see this part in here, but it's a mitral annulus on this side, the circumflex artery, and the tip of the appendage is in really close proximity to the left ventricle. Another way of looking at the anatomy is a view from anteriorly looking posteriorly, the atria being open and pinned. And you can see how the structure of the atrium in here is actually very thick. And then as soon as you get to the appendage, you have this translucent appearance with these big, thick facet muscles all over, both on the right and the left. So very thin, as you can see in these lines, the appendage. So what is the left atrial appendage and what does it do? There's been a lot of debate about it until recently. But what we do know is that the left atrial appendage is heavily connected to the nervous system, both parasympathetic and sympathetic fibers. The role of contraction is still debated. There's some contribution from active contraction of the appendage, and some is just a passive flow. And what has been seen by histological studies is that the left atrial appendage is a big reservoir for H1 natriuretic peptide. So the thought is that this is sort of a pressure sensor in your atria that in health and physiology, when we're young and healthy and we have no pathology in the heart, can actually sense the differences in pressure and then secrete H1 natriuretic peptide that serves as its own diuretic to maintain homeostasis. This is the key concept for this talk, that the left atrial appendage has been implicated in being the major source of emboli for patients that have non-valvular atrial fibrillation, more than 90% of the cases. It is also involved on the genesis of emboli for patients that have rheumatic valve disease and valvular atrial fibrillation, but slightly less than about 60%, which those atria are really enlarged and modified, and they can form all other crypts in there. The evidence comes from autopsy studies done especially at the turn of the century, 1900. The early experiences with rheumatic valve disease, these folks would pass away and then they would discover there were clots within the heart and in the appendage. And then subsequently in the 60s and 70s, when bypass started being being more performed, even the surgeons were able to see in the operating room the occurrence of clots in the left atrial appendage. And then lately, from the 80s on, we have evidence of echocardiographic origin of it. This is one of the first reports. It's from 1948. It's a cartoon that depicts finding a left atrium, left atrial appendage of a patient with rheumatic disease that passed away from a massive stroke. And you can see this is a cut from the intraventricular septum and intraventricular septum, and you see again the left veins in here, the appendage. This is a massive clot in here, and you can see the very tight mitral valve from rheumatic disease, schematic proceeding here, with a thrombus in the appendage and the thrombus in transit within the left ventricle. So the first depiction of the thrombi in echocardiography were done mostly in the late 70s. For those of you that are used to come to the echo lab and say, hey, look at these images, actually it looks like a heart that is moving. This is what echo used to be in the late 70s, early 80s when it started. So from the top in here, we see an electrocardiographic strip that has typically irregular pattern of atrial fibrillation. And the radial fibrillation up in here on the baseline. And when you put a probe, this is a monodimensional echocardiography, this is the chest wall. So you start seeing sternal or bony structures and then the chest wall. And the first cavity here is the right ventricle. The second one in here is the aorta with some of the motion. You can actually see the leaflets opening and then closing and then opening and then closing again. And then you see the left atrium. And in this specific representation, something is seen right in the middle of the left atrium, which by the way is very large in size. And this was identified as a thrombus. I don't think that I could sell this to you as a thrombus today, but this used to be the gold standard a few years ago. And then TEE studies that in the 80s, finally, when we were able to have probes that you can put really close to the left atrium, go in transesophageally, you can actually see a clot within the appendage. So why do thrombi form in the left atrial appendage? Well, it's a very complex scenario and it has to do with the size of the left atrial appendage, the flow pattern within the appendage and within the atrium in general, the flow velocity, and the morphology of the appendage. This is the only slide that is going to keep you guys awake. And basically, this slide comes from a group down in Austin, Texas, of ablations. These are the guys that basically do between 10 and 15 ablations a day. They have 5 EP labs that are dedicated to ablations only. When we do an ablation for atrial fibrillation, which we're not going to talk about today, typically we get a preoperative imaging to understand the anatomy of the left atrium. It's usually variable. You want to know where the veins are. You target the pulmonary veins, and you want to know the caliber and so forth. So what these guys did in their experience is they collected a lot of images on the left side of each panel in here. And I'm sorry, I can't show you the bottom of this. Unfortunately, there's other names, but we'll go through those. The left side of the panel, those are 3D reconstruction of CT, and on the right side of the panel, there are MRIs. And when you look at this, these investigators went back and say, is there a pattern in chaos? Can we find a specific pattern on left atrial appendage? And they actually categorized and classified the appendage in 4 different classes. This is the cauliflower or broccoli, and you can see in the 3D reconstructions, you have these small little tiny spikes in here at the tip of the appendage with a fairly circumferential and spherical image at the tip. You have the chicken wing, where it comes out and goes to the side without really having too much nooks and crannies. This is called the windsock for pretty evident, self-evident reasons. And this is a cactus, which is actually one that has become less and less common to describe. The majority of people now go by chicken wing, cauliflower, and windsock on. And then when they saw this, they said, okay, does it really mean anything? So they went back in the database. There's thousands of people that have been ablated. And among the people that were ablated, there were low risk of having a stroke. And we're going to talk about this a little later on. And the people after ablation were not placed on any coagulation. They say, was there a difference in stroke occurrence between the folks that had a specific shape versus another shape? And what they were able to see is if you had a non-chicken wing appearance in that population, you have a 5% chance of having a stroke versus chicken wing being 0.7%. So having a smooth surface of your appendage, less nook and crannies, less spots with blood connection in the leg, may actually decrease your risk of having a stroke. So I think the evidence points to the fact that a left atrial appendage serves as a reservoir that can form thrombi. And so what have we done about it for the last number of years? We've given anticoagulants. For a long period of time, the only thing we have available was warfarin. Now we have new medications in terms of these, what we call NOACs or DOACs, novel or dual oral anticoagulants. We're not going to talk in details about it, but that's what's available. And where does the evidence come from? So this is a compendium of the studies that were performed with warfarin. And SCAF and CAFA were North America. The other ones were in Europe. But basically showed when comparing warfarin to placebo in patients with atrial fibrillation, that warfarin gave a reduction in all-cause mortality of about 26% and a reduction of stroke of about 62%. So this is data from the late 80s, early 90s. I'd like to show one specific slide from one of the new trials. Averroes was a trial of one of the new oral anticoagulants called apixaban or Eliquis. And this trial was a little schizophrenic in its design because they compared Eliquis at a usual standard dose versus aspirin. And this was in patients that either could not be treated with warfarin or just plainly did not want to be treated with warfarin. So it's a fascinating slide on the paper itself where there's a table that lists all the reasons why people don't want to be on Coumadin. And the overwhelming majority of people just say, I do not want to take Coumadin, period. And so when we look at this, on the left side panel was the efficacy Kaplan-Meier curve, which actually shows hazard ratio. It's a little more complicated to show and understand. But clearly it shows a diminished risk of having an embolic event, which was tested by the trial with apixaban compared to aspirin. I mean, obviously you're comparing an anticoagulant versus an antiplatelet agent, so you would expect a better result. What was pretty interesting and shocking about the trial is the safety portion of it, where if you have apixaban versus aspirin, these curves overlap when it comes to bleeding. So the majority of people had similar bleedings with aspirin versus apixaban, which was interesting to see. So let's switch gear one more time, and how do we decide, out of the people that have fibrillation, who needs to be anticoagulated? So for a long period of time, over 15 years now, we have chosen some risk stratification algorithms, one of which was the CHADS-2 score, and more modernly what's endorsed by the guidelines is to use the CHADS-VASC score. Those are acronym, where C stands for congestive heart failure, H for hypertension, A for age, which gives you 1 point if you're older than 65, and 2 points if you're older than 75. D is diabetes. S is having a previous stroke with 2 points on this scoring system. VA is vascular disease, and SC is sex category, where a female gender gives 2 points. From retrospective epidemiological studies, you'll see the correlation between an increase in CHADS-VASC score, number of patients in the study, and an increased number of odds-adjusted stroke rate. Also, one of the other algorithms that sometimes we use, maybe not quite as frequently as we'd like to, is the HAS-BLED. And the HAS-BLED is another acronym where you have uncontrolled hypertension, abnormal liver function or renal function tests, the presence of prior stroke, labile INR, history of bleeding, elderly, and then drug use such as NSAID or alcohol. So 2 different categories in there. And you know, you can see that at an increased number of risk factors you have, there's an increased chance of bleeding per year. So when you sit on the fence and you're looking at the patient in the clinic, you say, well, your risk is maybe a little high, but also your risk of bleeding is pretty high, so you can have some data to show and to support your decision to recommend an anticoagulant versus not. Not going to talk too much about warfarin. I personally do not like warfarin very much. I think if we had a better drug, we wouldn't have the need to go into creation of new drugs or other devices or anything. Warfarin is a real pain to use. We're lucky to have our co-ed clinics in here. Thank you, Vince, for running that. That gets a lot of our headaches away. But again, it's difficult to regulate the INR. There's a very narrow therapeutic index. There's a variety of different things that are going against it. This slide is taken from a paper published in the Journal of Medicine in 2011 that showed the emerging hospitalization for the elderly in a period of time between 2007 and 2009. And as you can see, warfarin is the main one that is responsible for hospitalization of the elderly. Great to have new medicines on the board. The new kids on the block are not that novel anymore. They've been out for about 8 years. The problem with this is still the cost. I don't know how many reps come to your office every single day telling you that they're covered all over, but invariably the patient goes to the pharmacy, gets charged an arm and a leg, and they don't take the drug. And then the limited availability of antidotes. I'm not going to dwell on it too much. So the dissatisfaction with our current status of treatment for prevention of stroke with anticoagulants and the collateral damage on a variety of hemorrhagic strokes and other bleed that occur that cause hospitalization and high morbidity and mortality has led to the development of alternative techniques. And we look at the cardiothoracic surgeons for giving kudos and credit for the work that they've done. The idea that you can exclude or excise or staple or remove a left atrial appendage is actually coming from 1949, a long time ago. Dr. Madden reported the cases of 2 patients with recurrent embolic strokes, and they were able to go in and exclude the left atrial appendage. And these were folks with rheumatic heart disease. And in their follow-up of, I think it was 12 months or 10 months, these 2 folks did not have any recurrent emboli. So that was the evidence for about 50 years of 2 patients with rheumatic disease that served as the gold standard for the surgeon to chop off their appendages. I've given this talk in front of surgeons, and they said that everyone made the statement. So 50 years later, or more than 50 years later, finally the first trial called the left atrial appendage exclusion study came out with a feasibility study, and we'll look at it in a little more detail. And then they had other small trials with proprietary devices that were proof of concept of can we exclude the left atrial appendage. So every surgeon will tell you, well, I stapled that. No, I triple plane double mattress suture, close it. No, I used the blah, blah, blah device, the RF device, anything. There's a variety of different surgical techniques. I guess whatever the surgeon is used to, that would be the best. But it's good to look at it in a systematic fashion to really understand what works or not. So that's the first study for the left atrial appendage occlusion. Was 77 patients undergoing bypass. They either used a suture or a stapling device. They had postoperative TE, so these guys were followed pretty nicely. And they showed that the occlusion was only 45% if you have sutures. And if you use a stapler, it was 70 to 72%. So feasibility, not that great. Regardless, they went on to do the second left atrial appendage occlusion study. And the reference is going to be on the PDF. Are you going to have the PDF slides on the website? Yeah, maybe you'll see a little more of the slide itself. So the second was a cross-sectional study, about 2,000 patients undergoing bypass surgery, 200 of them in atrial fib, and only 51 were randomized in 2-to-1 fashion, left atrial appendage occlusion or excision versus anticoagulation. And the results show 1 triple-vascular actin inclusion arm and 3 anticoagulation arm. Yay, big success. The third study is actually the one that is powered to detect true differences and to be the gold standard for, should we occlude the left atrial appendage surgically or not. And it's enrolling patients right now. This was from the Canadian Society of Cardiology meeting last week in Vancouver, and they were just showing that. Sorry, this is a pure poor quality picture, but they're enrolling. They're actually getting more than 3,600 patients. They increased the enrollment. They should be done enrolling by the end of 2018, I believe, in May of 2018. So this will give us some indication if that's really a technique that will be still valid in the next years as opposed to being completely scrapped. Just to beat a dead horse and take another shot at the surgeons, this is the Cleveland Clinic experience for Mark Gillenhoff. Between 1993 and 2004, they prospectively followed everybody who had bypass surgery, and they saw that they had 2,500 patients that had atrial fibrillation and bypass surgery that underwent surgical closure of the left atrial appendage. Out of 2,500 people, only 137 underwent a post-op TEE to look for, for different reasons. In the meantime, we're looking at the left atrial appendage, and they saw that only 40% of these folks had successful closure. And what's interesting in here is they had no failure with the stapler, so you can see this is stapler at 0%. They had a 23% failure with suture, and the excision was 73%. So I'm not quite sure where to go according to the studies, but I guess that LAAO3 is going to show us the truth. I'm a little running out of time, so I'm going to go through the other slides a little more quickly. So the mantra in cardiology is, when we look at the cardiothoracic surgeon and we say, everything you can do, we can do better. So they do bypass, we do stents. They do open valve, now we do TAVR. They close ASD. I'm going to talk to you about closing PFOs and ASDs. And as far as the left atrial appendage, well, I guess we can occlude left atrial appendage just as well as they do. All this is a list of devices that have been either investigations in the past or are on the market or are in investigation right now. And the basic for percutaneous occlusion device is fairly similar for all except one. You do a typical cath lab procedure where you access the femoral vein, you get up into the right atrium, you do a transeptal puncture from the right to the left, you look at the left atrial appendage, you take pictures of it combined with echocardiographic images and fluoroscopic images with contrast, and then you drop a device of some sort within the left atrial appendage and then make sure that the appendage is closed. The first one that started this whole field was the Plato device. This is no longer available on the market, but the design of it will spur other devices out there. It's sort of a balloon with these flexible tines in here that are within a sheath, and then once you get to the left atrial appendage really close, you can push the device out and blow it up into the appendage. In the first feasibility trial of the Plato device, which was now published a few years ago, there were 100 patients that had CHA2DS2 score 2.6, so they deserve anticoagulation, and they had an annualized stroke rate of 4% when the expected stroke rate was 6.6%. But unfortunately, they have a lot of complications. These are major adverse cardiovascular events. 7% is a little too high for any procedures that we would advocate for. The second device is the implants device, or the implanter, and it's a double disc device. That's what Todd is going to talk about for the rest of his talk, so I won't go too much into it. But this device has been used not only to close ASDs and PF4, but also to occlude the appendage. This was an early experience. The study has been shut down with this one. They created a new device that is slightly different from the previous one. And after the FDA approval of Watchman, which we're going to be talking about in a minute, they had to reconvene and start a new clinical trial that is enrolling patients right now. The pictures in here of the Lambert device. Again, now this is a combined parachute and disc that goes into the appendage versus the wave crest, which is slightly different in design because it has tines in here that can actually connect it to the inside of the appendage. The next two devices are the one where there's more clinical experience. One is Lariat. Lariat is worth spending a few words about. So with Lariat, this is a suture loop that comes into a small device. And the difference between the Lariat and the other devices is that you don't leave anything in the endocardial surface from the conceptual puncture, but you actually occlude the appendage from the outside. So it's a combined procedure where you do a pericardial access substernal, and then you do a femoral puncture from the femoral vein. You have wires that go inside the left atrial appendage, and then a wire that goes on the outside epicardial surface of the heart. The wires are magnets, and the magnets hook together and touch together to give you a rail. And then you put this device over a rail over the appendage, and you close the appendage, and then you deploy a suture in there. The Lariat device was invented by a cardiothoracic surgeon who went to the FDA with this tool and said, I just want to have this tool out there for hemostasis. So if I have a vessel that is bleeding, I can just take this thing, slide it in, give a suture. It's just like the other sutures that we have. So can you approve this? And there's an exemption for the FDA called, I think it's a 501 or 503B, where the FDA says, well, it's a Me Too product that does the same thing, sure, go ahead and knock yourself out. Well, the problem is that the company had plans to use it percutaneously for occlusion of the appendage. And as soon as they got the FDA approval, they started pushing it into the physician's world and for off-label use. So that has gotten a really bad press for the device itself and was a sneaky way to get in through. We had some experience with the Lariat device here at St. Pat's. But unfortunately, there's no studies that'll show you that the Lariat device has any role in diminishing stroke in patients with atrial fibrillation. So the first experience was from a group in San Francisco and a group in Poland. They were able to get about 90 patients, 86 patients, 85. They were able to deploy the device. They looked at it and said, oh, this is feasible. And the second experience was, again, from the same group, published from the US. And in this case, they had 138 complete closure of the appendage. And in this slide, they're trying to convince us that these folks had a CHATS-2 score in the range of 2.5, and the expected rate of stroke should have been 6%, and what they observed with this was 1%, but also had 2.8 when you combine death, stroke, and systemic embolism. So, I mean, some efficacy in here, but these are all prospective studies. They're not randomized. They don't have the validity of the other studies that I criticize the surgeon for. So how can I criticize them and not criticize us? Can't do that. Then the next was the larger U.S. multi-center evaluation. This is from PJ Lafayette in Kansas, they Wilbur in Chicago. Again, now big numbers, 900 patients with some efficacy. Again, the efficacy data is not really that good, but what's really important here is the safety. A lot of people needing open heart surgery, a lot of cardiac perforation, and then eventually with the smaller needle would diminish, but still a pretty worrisome ordeal. What's worse is that the FDA has I don't know if you guys have seen it, but there's a database for ongoing monitoring of devices that are approved. And when one of the investigators looked at this database, actually there was a lot of complications with the Lariat device that were never reported scientifically, but they were in the FDA database. With about 30 patients going emergent to the operating room for open heart surgery for either laceration or avulsion of the left atrial appendage and a few minutes as well. So, not great data, a little risky, it's been spun in a different way. The companies try to reinvent themselves by doing a clinical trial for efficacy of Lariat in maintenance of sinus rhythm in conjunction with ablation, but it's very difficult to promote a device that doesn't really have that much data right now. So lastly, and we say the best for last, is the Watchman device. So Watchman is one of those percutaneous devices that we looked at it before. It looks like a parachute. It's an evolution of the Plato device, and it's the one that is being studied the most. There were two pivotal trials. One was called the Protect AF, 700 patients with a CHA2 score greater than 1. They were randomized to Watchman plus warfarin for 45 days versus warfarin alone. And the primary endpoint was actually stroke. They really wanted to see, do we diminish stroke with these devices? This is the randomization scheme and the on-treatment plan for the folks undergoing Watchman, which is still valid in clinical experience because it is being approved by the FDA, and that's the algorithm we should use. So between implant and 45 days, we keep patient on aspirin and warfarin. After 45 days, we check a TEE. If the left atrial appendage has been sealed, the warfarin can be discontinued, and then the treatment protocol is aspirin plus clopidogrel, and that goes for 6 months, after which you can stop the clopidogrel and then warfarin and stay on aspirin alone. And if there's no seal of the left atrial appendage, you continue warfarin and you check TEEs at specific times to see when the seal is adequate and discontinue the warfarin. Those are complex Kaplan-Meier curves of the main trial. I think it's a little easier to see on the forest plot back in here, where, again, unfortunately, the slide cuts off. But this is the non-inferiority margin, and if you look at the total, actually it's right in here and doesn't cross. So with the Protect AF, the company showed that indeed the Watchman device is non-inferior to Coumadin. They could not prove superiority, but they're non-inferiority. And when you look at the complication of the implantation of the device, when you look at the control, no shock that there's 4.1% of major bleeding and 2.5% hemorrhagic stroke with warfarin, and with the intervention with the warfarin, Watchman plus warfarin, it's twice as many numbers, and there's pericardial effusions, which are a big Achilles heel with these procedures in general, about 4.8%, but then massive reduction in hemorrhagic stroke. And if you take the data after the 30 days of the procedure, the numbers look even better. So the FDA evaluated this study, and they asked themselves, should we approve this device or not? And they asked the company to do a second study called the Prevail, which was an additional 400 patients, a little higher CHA2 score, similar primary endpoint. And following the publication of Prevail and presentation of the FDA was gave the approval in May 2015. Really quickly, we look at the primary endpoint. Again, very low numbers, and the curves are almost equal, and then diverge a little bit, with actually a little more event on Watchman than they have on warfarin. And that was pretty shocking to the investigators because they expected the stroke rate to be much higher, especially with a higher CHA2 score, and instead was low. As a matter of fact, in the original paper, the investigators look at this like, this is crazy, because when you look at big trials, so Aristotle, Rocket AF, and Rely are the Eliquis, Rivaroxaban, Xarelto, and Pradaxa, the Bigotrend, the three big new medicine that came out, where the expected rate of stroke was up in here, and in this Prevail trial, the rate of stroke with warfarin was much less. So we have started a Watchman program here at St. Pat's last year. Steve Shrepo sitting here in the audience has been a referral coordinator, has done a great job trying to field all the phone calls and try to organize and talk to patients and so forth. We're early into the experience still. About 45 patients have been implanted with the Watchman device. It's been a very humbling experience. It's a tough procedure to do, and there's definitely a high risk of pericardial effusion, as you can see from the slides, and how thin the appendage is. But we've been very happy with how things went so far. I'm not going to bore you anymore. I'm going to leave the stage here for Todd, and I think I took you more time than usual. If you guys have any questions, do you want to take them right now, or we'll do it at the end of the talk?
Whatever you want.
Do you just want to go, Todd, and then we'll take all the questions together? I would like to do so. Whatever. Yeah.
This is for the slider transfer, that's the. Do I need to do something different to get this to come up here? I'm plugged in here, so it's not coming up. I don't know how to get it to go. Just pressing buttons. I'll let this switch from now to this. Yeah, that's really good. Yes. That's the thing. Didn't I need to close it?
If you have a percutaneous fusion, what do you recommend? What do you do with the wall?
So the question is, if we have a pericardial effusion during one of these procedures, if we evacuate them. And so typically the first step that we do is a percutaneous drain. It's a subxiphoid puncture and try to evacuate the blood. And in most cases, actually resolves the hemodynamic compromise. And then you leave the drain in there, and typically the whatever perforation happened seals itself. And there are cases where you continue to have effusion, maybe the hole is a little larger, there's been more compromise. In that case, you mobilize the OR and take the patient to open heart surgery where they can put a pledge stitch on the perforation. Does it answer your question? Well, obviously, first of all, you make sure that there's no recurrence, so you take the drains out, and if everything looks good, after a few days, if you need to restart warfarin, you restart warfarin. Young minds? All clear or totally all muddy? It's one of the two. Yes, ma'am. Yeah, so after the FDA had the company go through, do a second trial and be, very tough on them, you need to show us this and the other thing,
they came up with a recommendation like, yeah, everybody was a CHADS VASC more than 3 can have Watchman. Thank you. So that actually has been a big concern in the field, and there's been a few academicians that have been very outspoken against Watchman. And I can't disagree too much with them. So from our perspective, when we decided to do this, we have started by screening the people that are the highest risk of having a stroke and people that have had significant bleeds. So our algorithm is to find people, and you've seen them in the hospital all the time, that were hospitalized for recurrent GI bleeds or a hemorrhagic stroke or an intraocular bleed, something that could be really dangerous, and you don't want to challenge them again with anticoagulation. And those are the folks that we're trying to identify. To the point that actually we had a few people that really were very nervous to be on warfarin altogether. So even the 45 days that they need to be in warfarin right after kind of makes us nervous. And there's been a couple of people where they deviated the protocol and just did not give them Coumadin and went with aspirin and Plavix right away. The other thing that scares me is the aspirin and Plavix issue. I mean, in cardiac interventions, we do aspirin and Plavix for a lot of people, post-stenting, post-PFOs, and so forth. Plavix is not a benign drug. It makes you bleed like stink. So it's been very worrisome for us. But yes, our criteria are high risk, so a CHADS VASC 3 or above, and then a good history of bleeding. Those are the best candidates. And I guess as we have more data available to us, then maybe we can lower the threshold. But I'm not advocating at this point that anybody who has atrial fibrillation or CHADS VASC 3 and has been stable either on Coumadin or Eliquis or something else with no side effects, with good INRs, should get a Watchman. That's not the intent. Oh. Okay. Vince. Yeah, so the aspirin on the Watchman procedure is after the Watchman, they get 81 milligrams of aspirin plus warfarin for 45 days. Then we get them back, and if they have a seal of the left atrial appendage on TEE, then they can stop the warfarin, and they go up to 325 milligrams of aspirin, and then add Plavix 75 milligrams once daily.
So the 325 is just basically because of the trial? The protocol trial?
Yeah, the protocol that we're following is exactly the same protocol to protect AF trial. So that's what's been approved, and that's what we follow. The 325 of aspirin in stroke prevention comes from those old trials, SPAF, the CAAF, and so forth, where actually there was no comparison between warfarin and aspirin, but there was comparison between aspirin and placebo. And when you compare warfarin versus placebo, there was a 60% reduction in stroke. When you compare aspirin versus placebo, it was a 30% reduction in stroke. And what you can't really make sense of is they didn't have any significant bleeding with aspirin during those old trials in the 90s. But now there's a lot of evidence from large databases, and including the FHRS trial, that aspirin is not that benign. There's a lot of bleeds with aspirin. To the point that right now the guidelines say if you have atrial fibrillation and a CHADS VASC 0, you should get nothing. Because getting on an aspirin could probably give you an increased chance of bleeding without protecting you from a stroke at all. Yes, sir.
Do you mind expanding on the use of aspirin in atrial fibrillation? Even if someone has a CHAD2 score, say, of 5, what is the evidence that aspirin is beneficial? Especially with the high morbidity, since our patients are elderly and the subdural hematomas and the bleeds. Do you recommend aspirin in this population?
This is not a very easy answer. So obviously, it's patient selection that is important. I just bashed aspirin for the last 2 minutes, but let's not forget that aspirin is a great medicine that has fantastic evidence in prevention of colon cancer, primary and secondary prevention of coronary artery disease, stroke prevention. So if I see someone with a CHADS VASC of 5 because they had a previous stroke, they're a woman, they have vascular disease and hypertension, you know, it's tough not to give an aspirin with someone who has established vascular disease. If it's somebody who had heart failure from an ischemic cardiomyopathy, tough not to give aspirin. And we usually give 81 milligrams, not 325. Although even that is debatable. It's a covalent binding of the COX-1, so it doesn't really change if you give 81 or 325. You achieve complete block of the platelets with whatever dose you give. But, you know, in your example, I think it's going to be very difficult to find somebody who has a CHADS VASC of 5 and does not require therapy with aspirin for other reasons.
How much AFib do you have to have to warrant anticoagulation? You know, we have a lot of patients that have pacemakers, and so we are constantly seeing brief episodes of AFib and asymptomatic patients, but you know, what my point is how much AFib do you have to start anticoagulation?
So thanks for the question. Number one, the first concept is that I want to leave you guys with. If you have paroxysmal atrial fib, you had 2 episodes over the last 2 years that you went to the ER for, got cardioverted and went home, and you feel every episode of AFib, you have the same risk if your CHADS VASC is high as someone who is constantly in atrial fib. Okay, so that's continues to be a paradigm and a dogma. There may be some reports of some folks that say this is not true, but the reality is there's an overwhelming amount of evidence that the reason for anticoagulating is not atrial fibrillation burden, is not the type of atrial fibrillation, but it is the CHADS VASC score. So that's the first concept. The second one is I was talking about wearable devices that people can purchase on their own right now, like, you know, the Apple Watch or the Cardia app on the phone. They can record great EKGs and so forth. But what about people that have pacemakers? We've been finding out that, you know, crazy enough, common things happen in common age groups. And since atrial fibrillation has a 10% chance of occurring in the octogenarian population, all the people that are 80 years of age that have a pacemaker actually is a lead in the right atrium that reads every beat of the heart and is able to monitor any abnormal beats that are more than 5 or 6 beats and tell you if the patient's had those beats or not. So who do you anticoagulate? And this is a field in evolution, and over the last 5 years there have been several studies. The first one had a cutoff of 5.5 hours. And he said if you have 5.5 hours of atrial fibrillation on your device, your risk is increased. And if you have less than 5.5 hours, your risk is not increased. The second study was a cutoff of 7 minutes and said if 7 minutes of atrial fibrillation occur on your device interrogation, you're at risk for having an embolic stroke. Less than 7 minutes, you don't. And there's a lot of other studies that are in progress right now to see how much is too much. There's a lot of retrospective study. The most interesting one to me was the TRUST study, which was the one that looked at the 5.5 hours. They were able to pull out of the study the people that did have a stroke. And when they look at them, they look at the pacemaker interrogation and they say, what is the temporal relationship between you having atrial fibrillation and having a stroke? And in my simple mind, I would think you go into atrial fib, you stay in it for a day or 2 or 3, and then you go back in the sinus and you're most vulnerable in those 48 hours. Well, only a few people did that. There were people that had atrial fibrillation a month and a half prior for 2 days, and then they had a stroke a month and a half later, maintaining sinus rhythm altogether. So the message from the trial is we still don't really understand what the real relationship between atrial fibrillation and embolic event is. And also, once you get to be in your 70s or 80s and you have comorbidities and your CHADS VASC is high, you're going to have strokes. And there are going to be strokes in patients that have Watchman device, Lariat device, Lambert device, wave-press device, surgical occlusion, and so forth, because there's still atherosclerosis of the aortic arch, because there's still other cardioembolic phenomena such as PFOs or other things that can happen, left ventricular apical thrombi. There's a variety of different things that being treated with anticoagulation actually can help prevent, again, at the cost of having higher risk of bleeds. Rachel.
A new problem that I've kind of come across is aortic stenosis with AFib. Can you comment on that a little bit? Is TAVR helping with that, or valve replacement helping with the AFib?
Yeah, that's another very interesting question. Thanks for bringing it up. There's this concept of atrial fibrillation as, well, I guess we expand a little more and say, what is atrial fibrillation? And I can tell you, I don't know. Why do we have atrial fibrillation? I don't know. Why do I see a 50-year-old whose BMI is 24 coming in with persistent atrial fibrillation and a 75-year-old with a BMI of 42 does not have atrial fibrillation? I don't know. Why does only 25% of people that undergo bypass surgery have atrial fibrillation? I don't know. Why does 20% of people that have valve replacement add valve replacement right after they have atrial fibrillation even if they didn't have it before? I don't know. And the concept of valvular atrial fibrillation is described by the guidelines in our studies as folks that have either rheumatic mitral stenosis, a mitral valve repair, or mitral valve replacement. So it's focused on the mitral. Now, are you going to tell me that having aortic stenosis with a mean gradient of 56 does not cause any hemodynamic compromise and an increased pressure in the left atrium that can trigger atrial fib? I'm not going to believe that. To answer your question, I don't think that either surgical aortic valve replacement nor TAVR have been shown so far to diminish the either burden or occurrence in general of atrial fibrillation. And the way that I see it, taking together all the data that we have, is that atrial fibrillation is supposed to be originating from the posterior wall of the left atrium and the pulmonary veins, where there are fibers in these areas that have been stretched by either increasing left atrial pressure, valvular regurgitation, scar in the tissue, whatever else, and they retain pacemaking activity, they fire inappropriately, and they create atrial fibrillation. Okay? So when you look at this and you see someone who has been compensating and maintaining sinus rhythm under this pressure for probably north of 10 or 15 years, because the progression of aortic stenosis goes from mild to moderate to severe over a long period of time, it's like having the Hoover Dam getting damaged by the high pressure of water every single day. And it's great right now, but what happens if there's one little crack in there? Then there's a second one, and there's a third one, and then the dam just destroys itself. So I sort of see it as you have reached the point of no return where your atrium said, enough is enough, I can't go back and stay in normal rhythm. And even if you change your parameters at that point, you've created so much substructural damage, scar deposition between muscle fibers, that it's going to be more difficult to retain sinus rhythm. Well, the discussion about ablation is different, and ablation is indicated in the current age only for folks that are highly symptomatic from atrial fibrillation. We don't advocate ablations for cessation of anticoagulation. We don't advocate ablation for everyone just because they have atrial fib. And, especially I'm not excited about seeing somebody who had, prior mitral valve disease and now they're atrial fib and they feel a little short of breath, maybe you should do an ablation. It's not something to be taken lightly. So if that person who had aortic stenosis and TAVR or traditional aortic valve replacement and, they're highly symptomatic in atrial fib, I think it's a valid option. Remember that atrial fibrillation ablation were studied first in young folks with paroxysmal atrial fibrillation and no other structural heart disease. And all of a sudden the field ran away with it and said everybody who has atrial fib needs to be ablated. So the data is lacking. Tim.
So just coming back to the question that Todd asked before, let's say I'm in the hospital, I'm getting ready to discharge a patient, they were in for pneumonia or something, and incidentally 30 seconds of AFib were picked up on tele. What is the current best practice? Is it to calculate CHADS2 VASC and kind of go from there in discussing anticoagulation? Would it be to prolong monitoring and see if there's more AFib that would emerge?
Yeah, so, it's a very controversial topic. There's no real randomized data to go after, and you just go by the risk of the patient and what you see. Technically, I know that many of you are ordering this. We have these fantastic 14-day monitors that you just put on the skin. They are very less intrusive than a Holter monitor or the other tools that we used to have. They're easy for the patient. They get very good tracing, good quality. And then we see this stuff where the patient has 16 seconds, 12 seconds, 27 episodes of 10 seconds top of this, what I call disorganized atrial arrhythmias, which unfortunately causes a lot of confusion, a lot of phone calls. But we don't know what it means. I mean, the definition of atrial fibrillation should be more than 30 seconds. But then again, the definition for being at risk of a stroke is 48 hours in the current data, because you wouldn't shock somebody within 48 hours if they haven't had a TE or now therapeutic on anticoagulations. So if you see that in that case, and if somebody with a high CHADS score and it's less than 30 seconds, I think it's worth doing a little more monitoring and see if they have any further episodes of atrial fib. But then again, you're looking at a picture in time of those 14 days. So that's not predictive of what's going to happen in the next year. It's only telling you what happened in the last 14 days. You should. That's the key word, you should. Yeah, so that's another very important point is, should you go and monitor more and for a longer time? And we do have available monitors right now that can last for 3 years. It's a small surgical procedure, and you can put these loop recorders in, and they're very popular, and you get data forever. But when you look at the evidence, these were used mainly in cryptogenic strokes. So there was a trial called Crystal IF where they took people with true cryptogenic shock, stroke, where they did MRIs, they did TEEs, they excluded any other sort of possible available known source of an embolic event, and they said, well, let's just try to monitor them. They actually found out that at 3 years, a lot of these people with cryptogenic stroke had about 60% chance of having atrial fibrillation. But they have not, again, I mean, maybe it's because things commonly happen in the common age group, and these were older folks, but they've seen, and they don't know if there's a true correlation between those. So I guess they're expanding upon that and taking the same patient and say, well, now that you find atrial fib, if we give you an anticoagulant, are you going to reduce your risk of a stroke long term? But how long term is long term, I don't know. So it's, there's no clear answers, and we struggle with this on a daily basis in clinical practice. There's no timeline that can tell you, if I haven't had atrial fib until now, I'm never going to have it. And this has become even more complex after you do an ablation, and that's the main risk for not stopping anticoagulation, because the ablations for atrial fibrillation do not have a perfect result. There's not a 100% chance of success. You can treat symptoms very well, and most people actually do quite well with an ablation, but you still can have subclinical episodes of atrial fibrillation, and then you still are at risk for a stroke. Well, great. If there's no more questions, it's now 8:30. I took my whole time, and questions? Thanks.